live. Greetings, everyone. Thank you for being with us today. Welcome to Hangouts with HIVE. Today's topic is Beyond Compassion, Caring for Women with a History of Trauma. My name is Yamini Oseguera-Bhatnagar. I'm the Power Health Coordinator at HIVE, which is a hub for positive reproductive and sexual health. It's the 28th of October in 2016, and I'm broadcasting live from San Francisco. I'm joined by some wonderful, amazing colleagues today. And without further ado, I'd like to introduce them to you. Let's start with Shannon. Shannon Weber is the director of HIVE and the founder of PleasePrepMe.org. She is passionate about creating a world where women have sex and babies when and where and how they want to. Thank you, Shannon, for joining us. Dr. Karen Scott is a Southern Black cisgender woman, physician, scientist who pursued medicine with the intention and motivation of achieving race, sex, and gender equity and inclusion in medicine and healthcare for women, girls, and young people of color. Instead, she found safety, visibility, affirmation, and community in the sexual and reproductive justice and youth empowerment movements. Her commitment is to the ongoing critique and development of the fields of sex and gender science, sexual health, STD and HIV prevention, and in partnership and centering the voices, experience, assets, needs, priorities of women, girls, and young people of color in the public health and health systems change in research, in evaluation, in dissemination, in implementation, and in digital storytelling. Dr. Karen Scott, so happy to have you. Jenee Johnson has been the director of the San Francisco Black Infant Health Program for the past 13 years. The program provides a direct service to Black pregnant women to address high rates of infant mortality in the African American community. Jenee is also a trauma-informed systems of care trainer for the San Francisco Department of Public Health. She's a certified professional coach. Jenee hails from New York City and is a graduate of Mount Holyoke College. Jenee Johnson, so happy to have you. Kelly Costello is an MSW program manager of New Beginnings at the Homeless Prenatal Program. She works with high-risk pregnant and homeless women in San Francisco who are facing complexity of challenges. Working with this population has always been a passion for Kelly, and she hopes to someday open up her own nonprofit. Kelly, thank you for joining us. Dr. Carmen Landau is a physician at Southwestern Women's Options in Albuquerque, New Mexico, where she provides abortion care in all trimesters. She completed her residency at the University of New Mexico and is a board-certified physician in family medicine. She attended medical school at the Latin American School of Medicine in Havana, Cuba, where she received a full scholarship in exchange for a moral commitment to provide medical care for the underserved, advanced abortion care, pain management for drug-using patients, and caring for survivors of trauma are her areas of particular interest. Thank you, Dr. Carmen Landau. Karishma Oza is the HIVE program coordinator based at Zuckerberg San Francisco General. Her passions include reproductive health and rights, HIV treatment and prevention, health equity, and increasing access to care globally. So happy to have you, Karishma. I thank each and every one of you for taking the time out today to share your knowledge and the skills you have acquired through your work. This is extremely, extremely valuable. A little bit about HIVE. Since 1989, HIVE, the former Bay Area Perinatal Aid Center, or BAPAC, has provided preconception and prenatal care to women and couples affected by HIV. Since 2004, all babies born in San Francisco have been free of HIV. Our mission is to advance reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. Our vision is to see a world where people affected by HIV have safe pregnancies, have reproductive autonomy, access to state-of-the-art healthcare, and most importantly, enjoyable sex lives. I'd like to share a couple of tips for viewers before we delve in to the content of the hour. We will broadcast for the next 55 or so minutes. During this time, as you listen to our panelists, please think about questions that you have for them and ask them in two ways. One way is to simply write them into the comments box on the YouTube page. And another way is to text them to this number, 415-842-2722. Again, that's 415-842-2722. You like what you're hearing? Show us some love on Twitter. Use the hashtag #BeyondCompassion throughout this Hangout and past it. We have and will be using hashtag #BeyondCompassion. If you missed the live broadcast and are watching the video of this Hangout, you can click on the slide before and after the Hangout to be directed to a list of resources relating to this Hangout that all the panelists helped put together. Lastly, while this Hangout, like much of the work that all of us do, is anchored in strength and resiliency building, some content may be emotionally or physiologically triggering. If you need to take a break, we very much support that. You can come back and pick up the recording where you left off or skip a part entirely. There is much work to be done in this world, and we must begin with ourselves. With that, I'd like to hand over to my wonderful colleague, Shannon Weber, to tell us more about trauma and the whole purpose of this conversation. Shannon?
Great, thank you, Yamini, and thanks to all of the panelists who've joined us. It's really thrilling to see such a powerhouse group of women coming together. So I want to talk about why we're here. 1 in 4 U.S. women have experienced gender-based violence, and among women living with HIV, these numbers are even more devastating. 1 in 2 women living with HIV have experienced intimate partner violence, and more than 60% have been sexually abused. This is 5 times the rate of the general female population. Consequences of violence, and we've seen this for years at HIVE Clinic. Trauma is associated with increased HIV vulnerability, higher HIV incidence, faster disease progression, and more hospitalizations. Unaddressed trauma is associated with twice the rate of death among women living with HIV. Women living with HIV have higher rates of tubal regret, meaning more women second guess their decision to have a tubal ligation, and for some women, this decision was made for them. Partner sabotage increases rates of unintended pregnancy. Partner contraception sabotage, increases rates of unintended pregnancy. And in 33 US states, there are still HIV criminalization laws that enforce long histories of systemic oppression and further stigmatize women. So why are we here today? Even in the face of these overwhelming and devastating statistics and outcomes, there is still hope. We can seek solidarity in our advocacy efforts and heal through relationships and connections, even as we continue to fight and create systems-level change. This is how Beyond Compassion was born, recognizing that compassion is just the beginning of a longer journey that we're engaged on together. So based on learnings from a day-long symposium that we held earlier this year, called Beyond Compassion, where we focused on caring for women with a history of trauma, we chose to adopt a healing and resiliency-oriented approach as we identified strategies for operationalizing these guidelines at the clinic and individual level. I want to share with you a manifesto that we made that will be linked to in the resources that you can download and print for yourself. There's several versions. You can print a small or a large version. We highly encourage you to share this with your colleagues. And so what are some of the things that we are doing here today? We're going to shift our focus from what is wrong with you to what has happened, moving away from blaming women and allowing space for our stories, staying curious, seeking to understand women's worldviews. We're committing to self-care and resiliency-oriented approaches to our own work. This begins with a commitment to heal ourselves and acknowledge that our healing, our collective healing as women, is a journey that we're on together. We commit to meaningfully include women's lived experiences. This means asking women for feedback on provider and program approaches, integrating women's lived experiences when we're designing new programs or crafting policies, hiring women for important roles, and creating space for women living with HIV to lead. We're going to use trigger warnings. Thank you, Yamini, for setting an example at the beginning of emotionally intense meetings or online content. And in order to mitigate women's sense of power and control that's impacted by trauma, we're going to turn commands into questions and really seek to provide opportunities for women to be in control. We're going to consider maybe she's not difficult, is that she's had a difficult life or experienced traumas that are difficult to integrate. And perhaps as she's navigating this fragmented system that we've created for her, if we can reframe and allow space for the experience she's living, it invites us to meet her where she is today. We offer choices, we commit to being present, and we recognize that there is always a source of light. So I want to invite all of you to join us today and every day on our Beyond Compassion journey. Thank you, Yamini.
Thank you, Shannon. You always inspire. Thank you so much for that. That manifesto is beautiful. Like Shannon said, it's going to be available for download and for printing, and we even have lots of copies to share. Some of the things that really speak to me from that manifesto are to break open whatever that might mean for us, to trust women. In some cases, that means trusting ourselves, and to model dignity. Thank you so much for sharing that. With that, we are going to turn over to Dr. Karen Scott, who will tell us about the numbers, about epi-data, about systems of oppression, about how those interact into the world that we live in, and what so many of the women, sometimes including ourselves, deal with when we walk through the doors. Dr. Karen Scott.
Thank you. So in continuing, I want to share that among women who are living with HIV, approximately 1 in 10 do not know they're infected. And in 2013, 84% of women who were living with HIV were linked to HIV medical care within 3 months, but only 55% were retained in care. And at the end of 2012, only about 39% of women were prescribed antiretroviral therapy, or ART, the medicines used to treat HIV. And likewise, 30% of women who also were living with HIV had achieved viral suppression. And data shows that Blacks are least likely to be virally suppressed, compared to 21%, at a rate of 21% compared to 26% of Hispanic Latinas and 30% of whites. So why does viral suppression matter? Well, it's recognized as an effective approach to prevent the spread of HIV to uninfected partners. It's also an important clinical indicator of overall patient health and public health. And although the data has shown that HIV diagnoses among women have declined 40% between 2005 and 2014, barriers to medical care access and retention, medication adherence, and viral suppression disproportionately affect women and girls of color, specifically Blacks and Hispanic Latinas, who are at risk for and are living in poverty, particularly in urban, rural, and suburban communities. Like HIV, the epidemics of substance abuse and gender-based violence perpetuated based on gender or sex identity, are affecting the everyday lives of women and girls in devastating rates and ways. So as many of you may or may not know, gender-based violence, or GBV, is a term that includes prevalent forms of violence against women and girls, including childhood sexual abuse, intimate partner violence, and non-partner sexual assault, as well as trafficking in the sex trade. So studies from 1994 to 2011 have described multiple pathways linking GBV to HIV among women and girls who use drugs. GBV disproportionately affects women and girls who use or inject drugs and significantly increases their behavioral and biological risk for HIV injection. Recently, in this year, in 2016, Decker et al. Described a study characterizing GBV and current forms of GBV, specifically intimate partner violence, non-partner sexual assault, and childhood sexual abuse, and described predictors of physical and sexual violence experienced during the 20 years of follow-up in a cohort of a group of urban women living with HIV and their unaffected women peers. So overall, the study revealed that 61% of women had a baseline history of GBV. It was prevalent among 81% of women who had experienced a transactional sexual history, 74% of women who did not identify as heterosexual, 84% of women who were currently homeless or unstably housed, and 64% of women with an annual household income less than or equal to $18,000, as well as 64% of women who are unemployed, 69% of women using alcohol in excess of 7 drinks per week, as well as in women with prior and recent injection and non-injection drug use, marijuana, crack cocaine, heroin, compared to other non-users. And over time, 10% of these women reported sexual and 21% reported physical violence. So having experienced all 3 forms of past GBV pose the greatest risk. Many researchers have characterized this synergistic interactions between and among the epidemics of substance abuse, GBV, and HIV/AIDS as SAVA, or the SAVA, S-A-V-A syndemic, a set of closely intertwined and mutually enhancing epidemics, which Gilbert et al. Described as being reciprocally influenced and sustained by the larger risk environment and broader power relations shaped by gender, race, ethnicity, and class. I would also add age, religion, and immigration status. Likewise, synergistic epidemics are further intensified by multiple political, structural, behavioral, and biological mechanisms. So with respect to persons living in the US with HIV, 8% abuse alcohol. 1 in 3 HIV patients reported using some form of an active drug. And we know that both alcohol and drug use are associated with poor ART adherence and viral suppression failure. And when we look at women who are living with HIV/AIDS, 55% have experienced some form of intimate partner violence. And in a sample of women living with HIV from 2012 data, about 38% of women had a diagnosis of a recent psychiatric disorder, of which depression was the most consistently associated with decreased adherence. So in a different review of the literature that was examining the SAVA epidemic, it looked at its impact on HIV-associated risk-taking behavior, mental health, healthcare utilization, and medication adherence, and the bidirectional relationship between violence and HIV status. So when focusing on healthcare utilization, the previous health services research demonstrated that HIV-infected persons come to the emergency department far more frequently than their uninfected counterparts and are more likely to be admitted to the hospital. So this kind of emergency department use correlates with high primary care clinic use, current or former illicit drug use, Medicaid enrollment, female gender, but not specifically with biological markers of HIV severity. So if the reason for frequently healthcare utilization cannot be solely explained by health issues themselves, then there are likely additional factors beyond the actual emergency department visit that are accounting for this behavior. So we see that research suggested that healthcare seeking behaviors may be influenced by experiences of violence, given the impact of GBV on mental health, substance abuse, and risk-taking. And in another study, they found that recent or ongoing IPV had a significant effect on healthcare decision-making, where the relationship between IPV and healthcare decision-making were strongest in the context of women who are experiencing alcohol abuse or current illicit drug use. And most recently, there was one particular study that finally linked the relationship between IPV and immune system. So when looking at 75 women who are HIV negative, if they had at least a history of IPV, they found that our immune systems would help to keep HIV levels lower and keep us from acquiring HIV were actually impacted just by having a history of IPV. So we finally have found an immunologic link between IPV and our immune system. So in terms of a call to action, we're looking at all the data that's connecting IPV and GBV along with HIV. The question would be, what can we do in healthcare systems to make a change? And I recommend that one thing in healthcare systems to expand our notions of what sex, why people are having sex beyond romance and reproduction, as well as building and applying a sex positive, human rights, empathic, culturally humble, and gender inclusive affirming approaches. As well as when we are looking in the ED room, just essentially screening for IPV, doing a brief intervention, providing resources, as well as screening for HIV, which has been done in certain places in the United States. That would be one way to begin to identify more women who are living with this condition. And in terms of what we could do in terms of research and evaluation, is simply just looking at different types of IPV and gender-based violence. We've narrowed them to physical and psychological IPV, but we've not really done a good job in surveillance data, looking at different types of GBV, and we've also not looked at youth, particularly as they are representing the highest new HIV infection rates. So that is, from a kind of epi standpoint, what's been happening when we look at women, being able to have more multi-level interventions that can help women deal with the challenges in their lives related to trauma.
Thank you, Dr. Karen Scott. I am most moved by your call to action, and I'm reminded of the manifesto that Shannon shared, which says to us, witness without judgment. How do we move in this world? How do we offer care in this world in a way that we witness what the women we care for are going through without making those assumptions and having those judgments around the reasons that people have sex and the reasons that they stay in relationships, etc. Thank you so much for setting the stage for the purpose of this conversation along with Shannon. With that, we will go to Ms. Jenee Johnson, who will tell us about community building, about thoughtful leadership, about the work of the San Francisco Black Infant Health Program. Jenee.
Thank you, and good morning, everyone. I am the director of the San Francisco Black Infant Health Program, which is one of 16 Black infant health programs in the state of California, addressing infant mortality in the Black community. In San Francisco, which is a world-class city, Black babies die at 3 times the rate of Caucasian babies in the first year of life because they are born too soon and too small. Black women have the highest rates of preterm birth. In years past, the common way of addressing preterm birth was to ensure that women get into prenatal care. It's a medical model. It was assumed that if a woman got into prenatal care and had her needs addressed in that manner, that the needle would shift. After 25 years of approaching preterm birth and infant mortality in that way, we have found that the needle did not move. What science is telling us is that we need to take a broader look at why Black babies die. And we need to look at what's called the social determinants for health, the things that impact wellness and well-being, the things that impact how a woman flourishes and thrives. And so in the Black Infant Health Program, that is exactly what we're doing. We are looking at the underlying culprits that impact women's well-being: stress, chronic stress, social isolation, and a lack of empowerment. Our program reaches women directly. Black women come to Black Infant Health when they are pregnant. They stay with us through 10 prenatal group sessions where they connect with other women that are in the same situation from similar communities as themselves. And then they also stay for a postpartum 10 sessions and some enrichment programs that we offer. In doing this, we touch women from every socioeconomic strata. What is interesting about preterm birth and infant mortality is that it touches every single Black woman, regardless of her economic status or her educational achievement. An educated Black woman, college-educated Black woman, has the same birth outcomes as the poor high school dropout who lives in Appalachia. College-educated Black woman, high socioeconomic ability, capacity, has birth outcomes that match a white woman who is poor and uneducated. What we are seeing in this is that women need nurturing and nourishing, not just paying attention to whether or not they get to a medical provider, but they need to be able to address long-standing, systematic oppression, violence, loss, stress, microaggressions, and the traumatic social conditions that make their life experience unique. And women across the board, as I said, regardless of socioeconomic status or educational achievement, Black women are dealing with these things. We are looking at Black infant health as an innovation project. It's an innovation project here in California, hoping to add to the national menu of options of addressing this issue of infant mortality, because we know that the infant mortality is directly linked to the health and well-being of the mother. So this collective consequence of poor birth outcomes, we are looking to move to a collective healing model in working with Black women in community, not just one-on-one in isolated home visiting models, which have their place, no doubt. But what we found is that women love being in community. And this young generation of Black women have not experienced being in community together. Often when a Black woman will come to our space, they will say, well, you know, I don't really associate with Black women. I don't do Black females. After they've had the experience of being in a positive, affirming, culturally uplifting environment, by session 3, they are hooked in. By session 10, they're crying. What? It's over? And saying, I have never had this experience before. So what we are offering is an opportunity for women to reclaim and restore and experience community, experience sisterhood, experience the acceleration of healing that happens when you do it in a group. Now, what does it take actually to do that? It takes for the staff to be on a pathway of consciousness and practicing self-care intentionally. It takes for the staff to be thoughtful, to be also on a path of understanding our own historical legacy of trauma and the consequences of systematic oppression. And it takes us to be deliberate in our own leadership and personal and professional development. It takes us stepping outside of the traditional public health models that often are built on institutional practices that are undermining to Black people and definitely undermining to the feminine soul and spirit. It takes us owning our intuitive strength. It takes us going back to capture our own history, because one of the consequences of institutional racism is that Black people do not have access to their own history. We know that as a staff, as we continue to, I do a lot of staff development that is way beyond what is even quote unquote recommended or permitted through various contracts, union agreements. I do way more, because what we understand is that there has been an imbalance, and in order to balance out, you have to replenish and refill and fill up the cup so that women are able to give from the overflow. This is a whole new concept, giving from your overflow, as opposed to giving from 50%, giving from 25%. What we know about women is that women are going to give out. it's in our design to nurture, and a woman does not have to have a baby to be naturally that a nurturer. It is in our design. So what we do in Black Infant Health is we practice gratitude. We have regular gratitude circles. We practice mindfulness. We open up our staff meetings and our program participant meetings with mindfulness. We practice exposing our clients to and ourselves to cultural icons so that we can be inspired by the legacy of resilience and brilliance of our ancestors. And we practice and sustain a community of sisterhood. It is, as I said, an innovation project. We look to the best practices of other organizations like Harriet's Apothecary in Brooklyn, New York, we try to incorporate best practices from other women's organizations and other Afrocentric organizations and the best practices in public health. But we are designing something new and something different. And innovation is fun and beautiful and challenging, but it takes keeping yourself filled, and it takes paying attention to yourself. Thank you.
Jenee Johnson, thank you. That was beyond amazing, as you are. There's so much that you just said that's so transferable to all the work that we all do. How can we be deliberate? How can we step outside? I'm reminded again of the manifesto. How do we meaningfully include women's experiences? How do we champion resiliency? How do we support self-determination? And how is self-determination about self-knowledge? How do we learn from the legacy of our ancestors? How do we embody that? How do we build a circle again? And I'm so inspired by your story about how women come in and they don't want to connect, and by the 10th session, they are crying. I feel that I've had that same experience in my own life. So thank you so much for sharing that. With that, I'd like to move on to Ms. Kelly Costello, who will tell us about the amazing homeless prenatal program and creating a trauma-aware institution, as it is in San Francisco, and a client-centered institution, and creating wraparound services that really meet women's needs. Kelly, take it away.
Hi, good morning, and thank you, Yamini and HIVE, for putting on this amazing event today. So I'd like to talk to you about the homeless prenatal program and how pregnancy is a really key opportunity for somebody to make changes in their lives, and maybe they haven't had the motivation to do so before. So I'd like to start by talking about the New Beginnings program, which I'm a part of. So the New Beginnings program provides intensive case management services to pregnant women who are at risk of poor birth outcomes or of having child welfare involvement. The pregnant women that we see have mental health needs, substance use, intimate partner violence, HIV positive status, high-risk pregnancy, transitional age youth, pregnant women who are chronically homeless, and most have a history of trauma. As I said, pregnancy is such a unique and special time in a woman's life where people feel really motivated to make changes. A lot of the women that we see have not sought regular medical care before they found out that they were pregnant. A lot of the women are using substances, and when they find out they're pregnant, they are motivated to reduce the use of those substances or stop using altogether. It's a great opportunity for women to seek therapy and start addressing some of their previous traumas, find stable housing, seek safety from their partner. There's so many different opportunities for changes during the time period of pregnancy. And if you think about, pregnancy, you only have a specific time period. You have 9 months or less, depending on when you find out that you're pregnant, to make these changes, and it's a really great time period. So at HPP, we provide trauma-informed care, and we really meet the clients where they're at. So when a woman comes in, you know, we don't make any sort of assumptions about their situation. You know, we don't say, oh, congratulations, you're pregnant, and, you know, kind of assume that they're happy about their pregnancy, because so many women have unplanned pregnancies and are not happy when they first find out. We have an outreach case manager who will literally go out and meet people where they are. She'll go to the encampments, she'll go to the hospitals, to the different clinics, and really, you know, meet them where they're at in the community. We provide wraparound services for our clients, like getting them into housing, into treatment program, advocacy for their medical care, mental health support, and other case management services. Homeless Prenatal also provides baby goods like strollers and car seats and diapers and baby clothes and blankets, and all the things that somebody would need before giving birth to their baby. So like I said, HPP provides a non-judgmental approach to clients. We don't force our own agenda. We're really client-centered, and we go off of what the woman says her goals are when they first come into our space. You know, we sit down and say, well, what do you want to accomplish? What are some things that you want to happen here? And we'll help you attain those goals. And then with this, we practice trauma-informed care with our clients by being realistic with our clients about some of their situations they might face during their pregnancy and postpartum. Like, for example, in San Francisco, the housing is very challenging to come by, and also access to treatment programs can be limited. So we try to be really realistic with our families about getting into housing, and, you know, letting them know how long it might take, or what are the steps they might have to do in order to get there. And also, if the family might be facing child welfare involvement after they give birth, we really like to inform the families that we're working with about these possibilities before they give birth, so it's not a surprise if that situation happens. We work with families for the duration of their pregnancy and in the postpartum months. Another amazing service we offer is our Wellness Center, founded by our Nancy for Peer. And our Wellness Center is a beautiful place that ensures our families have the same opportunities for healthy pregnancies and healthy babies. Our Wellness Center offers free acupuncture, prenatal and postpartum massage, prenatal yoga, yoga with babies, prenatal education classes, baby bonding and attachment classes, doula services, and so much more. And these amazing services are provided by staff who have been there and been in the client's shoes. One of the best and unique parts about Homeless Prenatal is that over 50% of our staff come from the community that we serve. At HPP, we have a community health worker program where former clients and people from the community can participate in a year-long paid training program that gives folks the opportunity to learn social services and also a chance to give back. And so then many of our community health workers, they go on to become case managers and managers at Homeless Prenatal. This is all enhanced by the actual physical building being trauma-informed. When you walk into the doors at Homeless Prenatal, you see colorful walls, pictures of families, mothers breastfeeding, and like strung lights from the ceiling. It's a really beautiful and warm space to be in every day. And not only does our staff have the firsthand experience, but it also gives our families strong role models and people to look up to. Our clients, they come in and they see how successful their case managers are and what a good example they are. And so they say, you know, I can do that. I can be that person someday. And it's just a really beautiful thing. So, you know, many women come through the door every day at Homeless Prenatal ready to change their lives, and we're there to support them every step of the way. And all of these things are what make HPP so amazing, and why I love working there and working with these women during the time of pregnancy. Thank you.
Kelly, thank you so much. The Homeless Prenatal Program is nothing short of inspiring and has so much to share with the world and with the country on how to move forward in a trauma-informed way and how we care for women. I just absolutely love that you said that women come into the door ready for change. I'm reminded of the manifesto and how important it is to put people first. Start from where they are today and to offer choices, to really break open, leave it open. With that, I would like to invite Dr. Carmen Landau to share with us about the work of the Southwestern Women's Option Center and her long history of work on trauma-informed care for women. Dr. Carmen Landau.
Thanks, Yamini. And first of all, apologies for popping in and out. I am multitasking in clinic today, and thanks for your patience. At Southwestern Women's Options, where I work, we care for women who are seeking abortion services in all trimesters of pregnancy. So we see a lot of women who come from very far away, out of state, sometimes from other countries, because they cannot receive abortion services due to their gestational age or other restrictions in their state. So it has provided us with the opportunity to really refine a lot of the skills and language around trauma-informed care that can really help these patients have the best possible experience that they can. And so typically when I do education around, see, I'm going to sign a piece of paper while I do this talk. Thank you. When I do education around caring for survivors of sexual trauma, which is one of the big parts of my life and working with medical students, residents, fellows, and other healthcare providers, I started off really focused on that as a specific demographic. And one of the concepts that I think has been really important to share with other providers, and that I really had to do a lot of learning on myself, was that rather than thinking that we can identify who the patients are that have a history of that trauma, we need to apply universal precautions. And this was a term that really became big when we became more aware of the presence of HIV in our patient populations, that you can't depend on someone having HIV positive or hepatitis C positive, for example, in their chart, or telling you about that, or you thinking you know who looks like they might have HIV or hepatitis, in order to use the tools that we have in order to protect ourselves, right? Gloves, protective eye gear, etc. And in the case of sexual trauma, we have really started to learn, at least here in this center where we take care of so many women, that you cannot identify a woman's history based on looking at her chart or looking into her eyes, that every single woman must be treated with care that is appropriate for that of someone who has experienced significant trauma. And so more recently, and I'll say that the recent increase in media attention to the Black Lives Matter movement and the police brutality that has been happening for centuries, but we are now becoming more aware of, has caused me to really open my perspective more and to look at what are the other kinds of trauma that patients bring into the room when we interact with them. There are many, many marginalized groups, including, I would say, women in general, but beyond that, groups who have had historically been exploited and brutalized by healthcare providers. And a patient need not know the historical background of that trauma in order to have inherited fear and mistrust of healthcare providers. And the more I learn about the history of the medical profession, the more my mind is blown by how brutal it has been. That much of what I do in gynecology and obstetrics is based on the experiments that one man did on many hundreds of slave women, many of whom died as a result of his experimentation. That prisoners were injected with cancer cells to see how they would grow. How in New Mexico, for example, where we have a pretty significant Native American population, there are still many Native women here in New Mexico who were sterilized without their consent. And again, an individual patient doesn't need to necessarily know about that history in order to know that for some reason they and everyone in their family has always been afraid of and not trusted healthcare providers. And that fear and that mistrust is reasonable. And it is not the patient's job to get over it. It is our job to work harder. And then the more I look at the bigger picture within the spectrum of trauma and healthcare, the more I start to look at other people who are in professions where they are supposed to be helping the more vulnerable members of our communities, like law enforcement, like educators, and where that trauma can also be a part of that experience and how they can work to begin developing some trust and within those communities. So those are kind of two really big takeaway points that I think that those of us who have started to use trauma-informed care in our practices can start to grow and develop those skills outside of that smaller spectrum, at least in my experience. So number one, using universal precautions so that we do not miss an opportunity to provide someone with the care that they desperately need and deserve. And number two, to remember at every step of the way the history that we bring into the room with those interactions. And myself as a white healthcare provider, I've got a couple of different layers of history that I need to work harder in order to have a trusting relationship with that patient. And sometimes healthcare providers of color feel, or women, for example, we feel like, well, she should trust me, I'm a woman. The people that have hurt her in the past have all been men, or healthcare providers of color oftentimes feel frustrated. Well, why isn't it that this patient, why doesn't she trust me or feel comfortable with me because I look like her? But when we wear a white coat or we wear scrubs, we bring some of that history with us. It might be a little bit less work, but we still need to work at it. So those are the two big takeaway points that I've been really emphasizing recently, and I appreciate everyone listening and look forward to hearing the next presenter's viewpoints.
Thank you, Dr. Carmen Landau. You do amazing work every day, and I just want to honor the fact that everyone that's on this Hangout today really lives and breathes their work, and that is so valuable, and that is what creates change. So thank you for that. I also just want to shout out that we're getting instant chat messages in the on the YouTube page, and people are tuning in from many, many different places, Canada, the East Coast, of course, here in California. I just want to acknowledge that and appreciate that. So please go ahead and use that form if it works for you, and show us some love on Twitter if that's your thing, #BeyondCompassion. Also, I just want to say about Dr. Landau's presentation, she really models what it means to transform as care providers, and to break open and to see a new perspective and to allow ourselves to be taken in a new direction and to see our work in a new way. And that is very, very important for us as we transform as individuals. With that, I want to turn it over to my very, very wonderful, lovely colleague, Karishma Oza. Karishma is going to tell us about vicarious trauma and about taking care of ourselves. Karishma, take it away.
Thank you, and good morning. I'm so inspired by the women on this panel and by many of the folks who are tuning in. I wanted to thank my incredible fellow panelists for your work in shifting healthcare settings from trauma-inducing to resiliency-based. In this final segment of the Hangout, I will address vicarious trauma. So the effects of trauma exposure on professionals, as Carmen was alluding to just now, were observed formally in the late 1970s in emergency and rescue workers who displayed symptoms similar to the trauma victims they were helping. I'd like to share a personal experience and just to come back to Yamini's trigger warning at the beginning. So I first experienced vicarious trauma a few years ago when I was working on a qualitative study examining sexual and reproductive health among female sex workers in Tijuana, Mexico. I started to have nightmares of women being sexually assaulted by taxi drivers, uncles, neighbors, strangers. And I started to hear the participants' stories in my head, making my own loving and intimate experiences difficult and impossible to enjoy. It was almost as if I was sharing the women's experiences myself. Looking back, I'm grateful to my advisor for checking in with me and for providing space for me to heal. So vicarious trauma happens when we accumulate and carry stories of trauma, including images, sounds, smells, any resonant details, which can then shape and shift our worldview. Vicarious trauma can manifest in many ways, including a disruption of hope and meaning. In an era of increasingly electronic forms of communication, it's also important to notice how vicarious trauma can manifest through email or social media. How many times have you received an email that was paragraphs long and shrouded in emotion? And what impact does receiving or sending a hurtful email have on our productivity and, more importantly, on our well-being? So why is vicarious trauma important to address? Vicarious trauma may consist of short-term reactions or longer-term effects that continue after our work has finished. Some research has shown its effects are potentially permanent. Trauma reactions are usually divided into 3 categories. The first is intrusive reactions. These include dreams, nightmares, flashbacks, any obsessive thoughts, physiological reactions, and, similar to my own experience, persistent re-experiencing of the traumatic event. Next, there are avoidant reactions. So this involves feeling numb or avoiding situations. And the third is hyper-arousal reactions. So feeling difficulty, having difficulty concentrating, being hyper-vigilant. And some other signs and symptoms include anger, irritation, being startled easily, overeating or undereating, diminished joy, and feelings of hopelessness. Vicarious trauma can also result in errors in judgment or mistakes and high worker turnover. Ultimately, vicarious trauma can also impact personal life and relationships. So how can we heal from vicarious trauma? Coming back to the manifesto that Shannon shared earlier, commit to self-care. Let's make a commitment to heal ourselves so we can be fully present for our clients and coworkers. Let's also make a commitment to notice when the people around us may be exhibiting signs of vicarious trauma. If you're a supervisor, what would it look like to have regular check-ins with your staff? Similar to the one that Jenee Johnson was referring to at Black Infant Health. If you're in a position to change the environment of your workplace, can you advocate for healing spaces and practices? So since we have this lovely interactive platform, I invite each of our participants to use the chat feature to share with the group a few of your own self-care tips. Now, I want to recognize it's hard to prioritize taking care of yourself when you're taking care of others and when the system makes it really challenging to do so. But ultimately, are we doing an injustice to our coworkers and clients by not taking care of ourselves? According to a wonderful book called The Body Keeps Score, the core of recovery is self-awareness. Mindfulness helps us recognize the ebbs and flows of our emotions, and in doing so, helps increase our control over them. I'm still working on what my self-care routine looks like, but I'm learning to recognize symptoms of stress and of vicarious trauma. I want to share just a few self-care routines that have helped me. Some of these include weekly yoga class. I'm not saying I'm going to go to yoga every day because I don't have time to do it. It's weekly. I can go once a week. Putting a 5-minute breathing or meditation ritual on my work calendar. Eating lunch outside. Turning off email notifications on my phone. Trying to minimize back-to-back meetings at work. And going to therapy. I find it really helps to have a buddy system to hold myself accountable. So while technology can be distracting, I want to highlight one app that's really wonderful. It's called Headspace. It's a course of guided exercises on meditation, and it has a few focus areas, including health, relationships, sleep, anxiety, focus, and the exercises range from 2 to 35 minutes. It even has this really awesome 2-minute SOS session to help in particularly stressful times. I want to end with a hopeful message that the experience and biologic effects of trauma can be mitigated by resilience. If trauma ruptures relationships, resilience is built through healthy social connections. What if we started thinking of resilience as relational and communal? How can we champion resilience and believe in healing? I invite you to join me on this path toward resilience and healing. And if it feels right for you, take a moment, write a commitment to yourself on a piece of paper in front of you. What promises can you make to yourself? How can you take care of yourself going forward? Thank you. From my family to yours, I wish you a very happy Diwali, the Indian festival of light over darkness. To quote HIVE's manifesto, there is always a source of light.
Thank you, Karishma. It's such a pleasure to work with you every day because you really embody so much of what was talked about today. I would like to say that we are a little bit over time, and our panelists have been so amazing. What I'd like to do is just read off a couple of the questions that came in, and maybe we can provide answers to those on our webpage later, and just select one of them for a couple of our panelists to answer so we may actually end on time. Some of the questions that came in: what contributed to the decline in new HIV diagnoses among women, and how can we build on that success? How do you center yourself and maintain a strong, powerful presence as you work within challenging bureaucracies? How can we talk more about pregnancy as an opportunity, and how can we support women postpartum to continue their resilience and progress? What attracts women to your programs, and what keeps them there? Let's talk about CPS and women's trauma. What's the trauma-informed approach there? These are some of the great questions that came in. I'd like to select one of these in the interest of time and ask some of you to answer mostly about how you take care of yourself in sort of continuation to Karishma's talk. Let's talk about how do you center yourself and maintain that strong, powerful, amazing presence as you deal with the daily grunt work and the bureaucracy that you work within. Maybe we'll have quick answers starting with Jenee.
Sure. One of the things that I do is I practice mindfulness, and I source the work of Thich Nhat Hanh. He's a Vietnamese monk, and he has actually these sweet little books on sitting, on eating, on love, on any number of subjects that you can read on your commute. Stick it in your bag, you can read it over lunch, but opportunities to remind myself to be still and to use the breath, because the breath activates the parasympathetic nervous system, which is the calming response. And so to take sips of breath, and in taking those sips of breath, you just take a sip of joy to center yourself and to be still. It doesn't have to be a whole 20-minute meditation. So keeping myself up on thoughts about mindfulness and actually practicing short little moments of deep breathing, that helps me.
Thank you, Jenee. Karen, would you like to share anything?
Sure, yes. And thank you, everyone. But same thing, like therapy. I've had a therapist trying to understand. I think Dr. Carmen was saying when you have these feelings and you're not really sure where they come from, they're historical. So for dealing with my own generational trauma within my family and the women in my family, I got a therapist. I also practice mindfulness and gratitude, as well as something, I forget the process, but I actually, when I am triggered, I need to identify those triggers. I sit with trying to understand the messages that they're telling me and the lies that they may be telling me, because there is my own truth, and really trying to reconcile and dismantle some of those, a lot of those notions and stereotypes about particularly being a Black woman, Southern physician, educated, all those things. So really trying to understand what triggers me and why, and then practicing ways to validate myself. Like, we may not be able to do something every single day or multiple times a week, but literally just doing things that affirm who I am, clarify my values and my strengths, so that when I am making decisions and when I'm building relationships, that I am aligning, those decisions are aligning with my values and enhancing my strengths and allowing for more agency and authenticity.
Thank you so much, Karen. Dr. Carmen Landau, any ways that you could share quickly that you center yourself in the midst of lots of craziness on a daily basis?
I would freely admit that I am not very good at taking care of myself, but I am trying. One thing that I have found to be helpful is I get regular body work, massage, and that helps me with some of the physical stressors of actually what I do with my body all day. But I realized that there was this other thing about it that was really important to me, and that was that once I had found this massage therapist who I trusted, and that I went into her care and I handed my body off to her, and I allowed someone else to take care of me and to not be behind the wheel for 1 hour. And that is an important thing, to be able to relinquish some control and to trust someone else to take care of you. It's not something that is easy for all of us, but I kind of feel like the harder it is to do that, the more you actually need to work on it. So that's one little thing that I do for myself. So,
thank you. Karishma, I know you already shared. Let's hear from Kelly. Kelly, anything you have to say about that?
Yeah, so I am also a work in progress with my self-care plan, constantly trying to think about new ways to, take care of myself and center myself. I find a lot of support in the staff at Homeless Prenatal. I just feel like, we're such a tight-knit community there, and we all know what we're going through, and so I find so much comfort in that. And then on a more personal, I really enjoy just being out in nature, being outside, going for hikes, and just connecting with nature. That really tends to ground me. But always looking for new ideas. And thank you, Karishma, for sharing some things you do for self-care, because I'm always looking for some new suggestions. So thank you.
Thank you. Shannon?
So we've got some bells we got in our office that we dong them. We gong them when the patriarchy is coming down on us, or when we're doing someone else's job. Which isn't to say that we won't do it, because that's what you do, but it's also like we have to say, this is not okay that this bureaucracy works this way. This is not okay that I am doing this way again. I'm going to do it because that's what change makers do. That's how leaders show up in the world. But I'm not doing it because I accept that it's an okay way that it happens. And I think that's a way that we can, within our team, we acknowledge that these things happening, or with the sound, right, of the gong. It's like, there's a way in which it's like, then I know I can figure out a way to take care of myself or support my team member.
Beautiful. Thank you for making that very important distinction, that we may show up, but we know when it's wrong. I want to just quickly say that many of the resources you've heard about today, hopefully all the resources that you heard about today will show up on our webpage, and we will definitely send out a link to that to all who registered and some. I'd like to close out. We're a couple of minutes over at this moment. I'd like to close us out with a poem as a way to thank all of you for sharing your time with us. This poem is called Beyond Compassion, and it was birthed at our trauma symposium a few months ago. Beyond compassion for the HIVE conference. The gates call me to move forward, to pass through thresholds that make you able to sustain you, the work, that make you able to sit in service, to model dignity, to recognize trauma, to take care of community, self, to live your intellect through your heart and be wise. The wise one asks, what's the beauty of what we attract? What's the beauty asking me to heal? The wise one remembers the breath. The wise one drinks the waters of nourishment and release. The wise one works with the shadow, knowing the shadow means there's always a source of light. The wise one asks, what are you teaching me? What isn't being seen, held? Oh, the gates call you, wise ones, to move forward, to attend. To what needs attending, what wants attention in ourselves and our inheritance. Call in your support, breathe, honor the spaces between, hold intention, clear, release. Put on your golden cape, heal and be healed, by Sylvie Alvicar from the Poetry School. Thank you all. This has been a pleasure. This was Hangouts with HIVE.